We are born to show it to you. We are open and available and we discuss everything. So let's talk about the things. I spent good 20 minutes on the thing and I'm short of time now. Guys, Osama, what are you writing? I didn't say a single word. Preparing forward. Now, you learn, like this activity what I am doing today is not a lecture. It's something challenging, something overviewing, and some important concepts. Some bridging. Now, we learn the quadrants of the abdomen. We learn the regions of the abdomen. And in that perspective, we divide the abdomen in quadrants. Easy, put 4. Clinician does that. You are taught 9 quadrants. You are right and this is right. Why we do it? Tell me, why we do it? 9 or 4?
To locate the organs easily.
To?
When you examine the patient, to know where the organ is. You don't have to look for
very
it.
Good, very good. What else?
Referred pain.
Referred pain, very good. What else?
Communication between the medical team.
Yeah, right. Good answer. What else? So if someone come to you and talking about, I have a pain here, doctor. Now doctor knows. Doctor is not a magician. But doctor knows by his understanding who lives here. Then doctor asks some question and which makes patient satisfied. Doctor says, is there anything, some vomiting or something like that, have you experienced? Yes doctor, I am also vomited. What you have vomited? How it was? Oh, this doctor is the best. What makes him the best? He has a thought process because he knows who lives in the right side and who lives in the left side. Left side patient is saying, oh, this he's putting his hand over the stomach area. Now, doctor is asking about vomiting. You put your hand on your back, I have a pain here. Doctor will ask you, is it in the midline? Show me where in the back. Okay, do you have some problem with your urine? Yes, it's burning. Have you noticed some change in color? Yes, it is darker. Oh, this doctor is good. But make him good because he can correlate. What patient is talking, he is going in the same line. And he is giving some clues which are surprising the patient and the family. But if patient is coming, doctor, I have a pain in my ear, and doctor starts, do you experience pain when you are walking? So now patient has a reservation. What the hell is going on? My pain is here and he's talking about my foot. Got it? So these are the regions. By knowing them, we learn them. No matter you learn 9 or you learn 4. But the bottom line is what? You know that at the end of it, who lives where. Like these organs, these things, where are they located? That you come to know. And when you know this much, that's important for you. Is it clear? Making sense to everybody? Guys, say yes or no?
Yes.
Now, going further. 9 quadrants, I agree. But how we draw 9 quadrants? What is the reference point? Can you suggest me? There are tall people, there are short people, there are big people, there are small people.
Umbilicus, maybe?
Umbilicus will
put it in the center of the mid
and put a compass and move around. Is a big person, then every dimension is gone wide.
Tubercle of the iliac crest.
Tubercle of the iliac crest, what you do with them?
We make an intertubercle line.
Intertubercle line. Guys, do you understand what Tariq is trying to say?
Yes.
A little bit. So Tariq, can you make him clear?
Yeah, in the iliac crest we have a region that raised area in the iliac crest, sometime in the middle. Okay. If we draw a line between this area and the tubercle, we're going to make a line.
Understand now? Good. Thank you, Tariq. So this is one reference point. Is there any other reference point?
The rib cage.
Rib cage. What you get from the rib cage?
We can actually locate the organs below the rib cage, so we can.
No, but the lines. I'm talking about lines.
The lines. There's itself.
Really?
And the place, the area where we have true ribs. Where
No,
the
true
cartilage
false
is.
ribs has to do nothing
It's
with
the
that.
top
With the
line.
cartilage.
No.
Earlier cursed.
Gentlemen, are you part of this class? Why are you texting? Can I ask you to leave?
I was just checking this.
Well, is that important? Go and check and finish your thing and then come and join us.
No.
So now I have this reference point. I call it anterior superior iliac spine, pubic tubercle. Now these lines, I don't know what is the reference point. So I was told by someone, have some planes, have some concept, and that says two vertical lines. And if you track these two vertical lines, what you'll see surprisingly, these vertical lines are corresponding from the mid of the inguinal point, and if you track it upwards, it's going to the clavicle, mid of the clavicle. Make sense?
Yes.
Two vertical lines and two transverse lines. One was set by the tharynx between the two tubercles of the iliac crest, and there is another one. So this one is, number one is at the pylorus of the stomach, across the transpyloric plane. And second one is between the two tubercles. Make sense? Now someone said very nicely, so I'm coloring up these regions. This is my epigastric region, this is my umbilical region, this is my suprapubic region. Now what is the significance? Now someone is coming to you, doctor, I have severe pain here. Now I start thinking something wrong with the stomach, something wrong with the gallbladder. What is common between these structures?
Same quadrant.
They are
Supplied by same.
the derivatives of my foregut. So all the foregut derivatives, their referred pain will go to the epigastric. All the derivatives of the midgut, their pain will be referred around the umbilicus. All the derivatives of the hindgut, their referred pain will be going towards the suprapubic region. Got it? So if I know who are the hindgut people and who are the midgut people and who are the foregut people, I am able to pick it up very easily. No matter I memorize the exact location or not. Make sense?
Yes.
So this helps me. Now I can fill in the blank by putting the other names of the different other quadrants. So do you understand what this 9 how it is helping and that 4 how it is helping? Even we can use this 9 for that purpose. If you don't want to do 4, I have no problem. Clear?
Yes.
Now going further. Rectus sheath. You took a lecture on anterior abdominal wall. I know it is done. Now, hoping best you'll be knowing the things. Can anybody will tell me now what is a rectus sheath? Yes, my dear.
Yes.
What is rectus sheath?
Rectus sheath. Should be that side.
You know, if you have this answer, should be that side. How you'll put it? How you'll write it in the exam? You draw your picture and putting your hand and write should be there.
Extended.
Is this the? You know, if you write this answer, will you be graded
No.
nicely?
Extending from the costal cartilage.
Nizami,
It's the fascia which connects the external and internal oblique.
really?
It's a sheath that basically sandwiches the rectus abdominis.
Very good. This is the answer. That is needed. Who makes this sheet? Talal. Who makes this sheet? I'm asking you.
Me?
Yeah.
Transversus, aponeurosis, and internal oblique and external oblique.
Good. So now we know that we have two straight muscles. We call them rectus abdominis. Agree?
Yes.
And now this whole story of rectus sheath is going around the rectus, these recti. So I like to cut above one plane, and that my one plane is, it's not going up anyways. So I like to cut above the anterior superior iliac spine, and the other plane will be below to the anterior superior iliac spine. So now, We made a cut at the point A and a cut at the point B. So my reference point is anterior superior iliac spine. You agree with me? Now let's see what happens. This is the outcome. We have two images. The first image is above the anterior superior iliac spine and the lower image is below the anterior superior iliac spine. Let's make it. We know there's skin, superficial fascia. Now there was a question like that in SEQ. What structure you meet when you expose the artery in the cubital fossa? And the answer was skin, superficial fascia, deep fascia, and the aponeurosis of biceps brachii. And people, those who write all four, they get 3 out of 3. And those who didn't put all 4, they get maybe 2, 2.5, 1.5, or 1. But answer was so easy. So now, under the skin we have superficial fascia, then I have external oblique, I have internal oblique, I have transversus abdominis on both the sides. You agree with this?
Yes.
And then our target is what? Rectus abdominis. This is what has been said. These aponeuroses, these muscles are doing what? They are going across this rectus sheath. So now, external oblique aponeuroses go in front of the rectus abdominis. Agree? Transversus abdominis goes behind the rectus abdominis. So they are making the anterior layer of the rectus sheath. Who makes the anterior layer of the rectus sheath? External oblique. And the one who goes behind makes the posterior layer of the rectus sheath. Clear? Now internal oblique, it splits around the both. And the place where they meet all of them in the midline, we call it linea alba. Why we call it linea alba?
The white line.
Linea is line and alba is white. Albumin, white. Is that clear? That is needed. This is my anterior rectus sheath, this is my posterior rectus sheath. You all agree with that?
Yes.
Anterior rectus sheath, above the anterior superior iliac spine. Who reinforce it here? The external oblique aponeurosis and internal oblique aponeurosis. And posteriorly, transversus abdominis aponeurosis and internal oblique aponeurosis. And now let's go for the lower segment. Below the anterior superior iliac spine, we have the same arrangement, but what is happening now? See that.
Membranous line.
All of them going in front. So there is only anterior rectus sheath and there is no posterior rectus sheath. Is this clear?
Yes.
So we don't have posterior rectus sheath. So this in yellow box is the key point. In this yellow box, can you see that? This is the key point. This is one of our very pet questions. For last 6 years, every GI exam have it. Now,
so
what is this?
why we don't have the sheet in the posterior side when we cut below the ASIS?
It's not there. It's like the aponeuroses are not crossing behind. That's why.
It doesn't reach that far. Also.
No. Shh. Uday. Let's answer his question. He said, why we don't have posterior rectus sheath in this place? Osama, the question is, they all go in front, so we don't have anything coming behind. So below, in the lower segment of our abdomen, we don't have posterior rectus sheath. Why we don't have it? I don't have the answer for that. But we don't have it. Clear? Now, what is this? I have cut at this level. What level? Above the costal margin. So there is no internal oblique, there is no transversus abdominis. So only you can see behind are the ribs and in front is the aponeurosis of external oblique. So I cut where? Above the anterior superior iliac spine. Now you see something different here. And below you see something different. What you notice here in these two pictures. Above the anterior superior iliac spine there was superior epigastric artery. And below there was inferior epigastric artery. Because this superior epigastric artery coming from the subclavian artery, through its branch internal thoracic artery, that bifurcates into musculophrenic and superior epigastric. And from my femoral artery, I get inferior epigastric. So superior epigastric coming from above, inferior epigastric coming from below, they run within the rectus sheath and they meet with each other. If my superior vena cava blocks, blood may divert from the superior epigastric through the inferior epigastric, going to the inferior vena cava and going to the heart. If inferior vena cava blocks, blood may divert in other way. Make sense? Now, what is this I'm showing here? Stomach. There's a cut made in the stomach. And you're looking at it and stomach is lifted. So you're looking at the structures who makes the bed of the stomach. And there is my epiploic foramina. So right now we are in the lesser sac or we are in the omental bursa. Is this clear?
Yes.
Let's try to localize it. There you can see this is the cardiac end of the stomach and this one is the pyloric end of the stomach, and this red margin demarcates the boundaries of my epiploic, not epiploic but lesser sac or omental bursa. In this image, transverse colon and all that is visible and you are looking at the same extent of the lesser sac. And there, in this vertical transposition, you can see that where is the lesser sac or bursa omentalis. Clear? Going further, in the transverse section, the area which is enclosed by this red lining, that is what we are looking for. Now, what is the significance of this omental bursa? Anybody can tell me?
It offers a space for the stomach to enlarge.
It provides a space for stomach to enlarge, yes, little bit. What else?
The accumulation of, there's something, the accumulation of.
Anybody can think?
Maybe if we have ascites.
Separates stomach from kidney.
Well, kidneys are far away.
Does it include the portal triad? The three.
So maybe if we have ascites here, we can do it. We can cut.
In pancreatitis, that is a chemical injury, chemical burn to the pancreas. Pancreas releases an enzyme, its secretions. And then as a complication of acute pancreatitis, who get pancreatitis? Most of the people, those who drink alcohol or those who have gallstones, the stones in their gallbladder. They develop a special condition called pseudopancreatic cyst. Across the pancreas, there is a cyst form and there is a fluid accumulated there. Now, what happens because of that? This fluid is there and patient is in big trouble. What we do, we go inside through the stomach and we connect this cyst with the posterior wall of the stomach. We make a communication there. Now, the fluid which is accumulated, because otherwise we aspirate the fluid, it's been reformed again. So now we make a continuous connection between this pancreas and this stomach. So now all whatsoever is accumulated is drained into the stomach and drained out. And this is a specially designed sort of procedure, and automatically when there is no fluid, it will heal out. So this is another place where we can access, and this is the location. There are so many applications for that. But if you remember, this one is fine, but if you don't know it, it's okay. It's too much for you at your level. I just mentioned. Now, but you need to be expected to know it like that. What are the boundaries of it? Where it is and who's what. This is the description of the same thing. But I have explained in the tabulated form and there is in a essay format. Now, what is this? Six packs. Okay? What is the mechanism? Why we have six packs?
Rectus femoris. And
What's wrong with the rectus?
it's divided by the. No, the.
Like, we work out, our biceps grows this big. We show it, oh wow, what a muscular person. Pecs grows this big. But why we have six packs? Why we don't have six packs in the chest?
Because the fascia that covers the rectus.
No. When we do workouts, fat goes away, fat burns out, muscle become hypertrophied. Now this muscle shows interdigitations. Usually they are 3, but they can be 4. If they are 4, we have 8 packs. If they are 3, we have 6 packs.
Can be less, right?
No, 3 or 4.
No, because
Commonly
10
3,
and 4. Just
commonly 3, sometimes 4. Is this clear now? If someone asks you what is the 6-pack thing, so you can have some idea. Now, arcuate line. What is arcuate line? We refer it above the anterior superior iliac spine or below the anterior superior iliac spine. But internally, from inside, how we can differentiate? The place where we don't have the posterior rectus sheath, so now there is a line appearing. And through this line, what passes inside inferior epigastric vessels? I'll show you in the next picture. But before that, in the 9th quadrant, transpyloric plane, we know it. We talk about it. Now, this is again an important thing. Throughout your GI, you should be able to understand the sites of the referred pain. Even can you see this yellow dot? Stomach pain may come to this place. Pancreatic pain may come to in between the two shoulders. Sometimes somebody write an MCQ where it says patient has severe pain and epigastric pain which referred on his back. There is a history of alcohol consumption or history of gallstones. Now the clue organ is pancreas. So when we write an MCQ, we give you a situation, we give you the reference point of the pain, and then we give you a clue also. So every question has an answer, every question has some clues, and every question has some distractors. If you are smart enough, you can play with these. And if you are not smart, exam was very easy. And what you have done, you messed yourself. What I noticed, those exams who appear hard, they are high scoring exams. Those exams where you think they are very easy, they are hard scoring. There you score less. In hard exams, you score more because you think more. Soft exam, give away. Like Talal mentioned. Class, this drop, we know it. But that was an implanted thing. To test you and give you, to tell you that don't write what you see, just read what you need to ask.
How can we relate this pain in the stomach with the pain in the back?
Sama, I said this we'll be learning throughout the process. If you want this answer, I'll do it. How we relate patient has pain in his heart and there is ischemia. Why this pain goes to the ulnar side of his upper limb, why this pain goes to his jaw, why this pain goes to his tip of the shoulder. There are nerves connected. There are referred pain sites and there are things. That is the logic. Why the gallbladder pain goes to the tip of the shoulder sometimes? Why the diaphragmatic pain goes here? There are connections. We had the phrenic nerve which comes from the neck, goes and supplies to the thing. So there are so many developmental reasons and nervous connections. And that is what is needed. To be a good clinician, you have to be able to anticipate all that. We are not expecting you a clinician today, but tomorrow you are, inshallah. Now, you are looking at a dissected picture of abdominal muscles and you are looking at external oblique. See that very carefully. External oblique, look at the direction of the fibers, but above the anterior superior iliac spine there is no muscle. In the midline there is no muscle, it's all epineurotic. And there you can see the rectus abdominis. Can you see that? Yes. And now, what I was saying, the arcuate line. See, my inferior epigastric artery. Enter because there is, see this green is the rectus sheath, anteriorly and posteriorly. So it can enter very easily in the rectus sheath. So rectus sheath you can see superiorly we have superior epigastric, inferiorly you have inferior epigastric. Make sense? Same picture. Now this is important. How? This is someone's abdomen. You are inside and you are looking at from this place, from inside. You are at the back. And now what is visible to you? Inferior epigastrics. Inferior epigastrics. Arcuate line. Arcuate line. Inside the abdomen. Outside you can see anterior superior iliac spine. Now, the very nice picture showing you the umbilicus and anterior superior iliac spine. You can see it here. The umbilicus, anterior superior iliac spine, and there is this number 11 is the point where the lateral 1/3 and medial 2/3 meet, and that is called as McBurney's point. So pain of the appendix usually starts around the umbilicus, then it is settled. It's a classic. You ask the patient, where is the pain? Here. Where it started? Here. Khalas. Appendix. You are 90% confirmed. Now you are not sure yet. Press it. Look for other signs. I'm sure you are not done yet with the signs, so just sabr. But then we have confirmative. So appendix is a type of disease. There's no lab test, definitive lab test which tells you appendix is there or not there. Unless you do a CT scan and all that, that may tell you. But otherwise, the physical examination and history tells you all. Now what is this? You are looking at a laparoscopic view inside the peritoneal cavity, and there you are looking at inferior epigastric. You are looking at the testicular vessels. You are looking at the vas deferens, and they are entering into the deep ring. You have done the deep ring now. You have done the superficial ring. Now these are the facts which you need to be good at when you are learning esophagus. The narrow sides, the constriction points, its close relationship with the left atrium of the heart, and portal and systemic anastomosis sides of the veins, and the occurrence of the esophageal varices. Now what is this is happening? Pringle maneuver. Who is this? James Pringle is the one who described it. I will come to that shortly. Now let's do the blood supply of the stomach. I know you did it, but let's go short. Now there you are looking at what? The abdominal aorta, celiac trunk. You need to be good at what level abdominal aorta enters the abdomen. What is the level of origin of celiac trunk? What is the level of origin of superior mesenteric artery? At what level we have the origin of inferior mesenteric artery? So these facts should be on your fingertips. So now you are looking at the celiac trunk, and it gives three branches. One towards the liver, we call it common hepatic. One towards the stomach, we call it gastric branch. It's because stomach is on the left side, so it's left gastric. And one is going towards the spleen, is running over the pancreas. We call it splenic. So these are the three branches of the celiac trunk or celiac axis. Make sense?
Yes.
Now, same picture, we just said it before. Common hepatic, left gastric, and splenic artery. Now this common hepatic is going towards the liver. Now this is proper hepatic. And other end is going down behind the stomach towards the duodenum and pancreas. We call it gastroduodenal artery. The one which was going to the liver has two lobes. So must bifurcates into right and left hepatic artery. Gallbladder is in the neighborhood. So right one supplies the gallbladder. We call it cystic artery. Make sense? Now we can see that this gastroduodenal is passing behind the pylorus of the stomach. Now there I am showing this yellow dot. What is the significance of this point?
It's susceptible to ulcers and posterior perforation.
What is ulcer?
It's a cut in the mucosa.
Cut in the mucosa. How it happens? You put a knife and
No,
cut
the
it?
acid.
Acid is there always or sometime?
As soon as we open the sphincter, some acid gonna go, and it was continuous. It can cause.
Tariq, say loud.
mucosa.
Say it again.
Continuation and exposure of acid in the duodenum, in the first part of the duodenum, can cause cut in the mucosa.
So now, what you are saying, people have only duodenal ulcer. How you explain gastric ulcer? It means there is no gastric ulcer.
No, there is.
So then, which sphincter does that?
Gastric ulcer, the lower lower esophagus.
Sorry?
Gastroesophagus.
Don't mess around. Don't mess around. Before you are getting marks, I know your marks are getting in zero. Minus.
Esophageal sphincter.
Who causes damage in the mucosa? Yes, Osama.
What causes damage is the carcinogen, which will.
Carcinogen, everybody has a cancer?
No, not the cancer. The carcinogen the
The
proteins and
ulcers
DNA
are
sequence.
associated with Helicobacter pylori.
Helicobacter pylori story will start later. Yes.
No, I was
Razwan.
saying the same.
Guys, Uday, you want to say something?
Yes, there's the chemical secretion which neutralize.